Hello, everyone, and welcome to VIDA News Live. I am your host, Dom Garrett, and as always, thank you so much for taking time out of your day to join us on the program. Our topic of conversation today is why bans are not best in Africa. As you may know, we are currently in a series here at VIDA News entitled Why Bans Are Not Best in LMICs. The reason why we felt that we needed to have this topic of conversation is in response to a paper that the tobacco control group, the Union, which is funded, I should say, in part by Michael Bloomberg, they released a position paper a couple of weeks ago entitled Where Bans Are Best, talking about the fact that all LMICs, or low and middle income countries across the world, should not work on regulating safer nicotine products, but instead they should ban them, all while they leave dangerous combustible tobacco on the shelves. Now, health advocates around the world have applauded the use of harm reduction tactics in curbing death and disease in Africa for decades. However, because of these privately funded NGOs, many countries inside of Africa have opted, again, not to regulate, but instead to ban or restrict these products, all while people still have access to the combustible tobacco that we know causes death and disease. And so our panelists today are three champions of harm reduction in Africa, and I personally am thrilled to have them on the program. And so I would like to welcome our panelists onto the program right now. First, we have Joel Sawa, who is an activist with Tobacco Harm Reduction Uganda. We have Joseph Magero, who is an activist for the Campaign for Safer Alternatives. He lives in Kenya. And we also have Dr. Kgosi Latlape, who is the co-founder of Africa Harm Reduction Alliance, as well as the former president of the World Medical Association. Gentlemen, thank you so much for joining me on the program today.
It's a pleasure.
It's a pleasure, and good morning on your side. Good evening for us.
Good morning over here. Good evening there. So what I would like to do, I obviously know quite a bit about you, and I'm sure that our audience does as well. But I would like to give each of you the opportunity to introduce yourselves and tell us a little bit about your journey into the world of tobacco harm reduction. Joel, I would love to start with you.
Thank you, Dom. You rightly introduced me, my name is Joel Sawa, a tobacco harm reductionist in Uganda. I've been doing this from 2019, last year. I was introduced to this through Campaign for Safer Alternatives, my chairperson being Joseph Magero. And it's been quite a journey. It's been turbulent, various challenges along the way in terms of how tobacco harm reduction is perceived. Actually, it's perceived more to be more of a danger rather than of any good. So the challenge on us is to try to demystify the understanding of what tobacco harm reduction is, so that the general public, even so the smokers, can get to understand that there's an option, rather than them simply having to struggle with the quit or die option. There is the option of indulging in other options, which would, rather than take them down under, they would actually give them a better way to enjoy what would otherwise perceive as evil, so to speak. Nicotine in itself is not evil, but smoking and the tar is the problem.
Yes, I know that you recently wrote a blog post where you brought up that exact phrase, that the death comes from the tar. It's not from the nicotine. It's the smoke that kills. Thank you so much, Joel, for coming on. Joseph, I would love if you could go next. Please introduce yourself to our audience. Oh, looks like we actually are having a little bit of difficulty with Joseph's audio. While we get that fixed, while our production team works on that, Dr. Kagosi, if you could do me a favor and introduce yourself. We have some things from your resume. It's long. You've done this work for a long time, but please tell our audience, why it is that you find yourself here in this battle for tobacco harm reduction.
I'm an ophthalmologist by training, and I'm in private practice in Johannesburg. I've been in medical politics for as long as I remember, for more than 30 years. I'm a past chairperson of the National Association. I've been involved in Africa and in World Medical Association. And my journey started in the WMA with a Patient Alliance, International Association of Patient Organizations, where I started to look at things from the perspective of the users and the patients. I'd also been involved from early 2000 in HIV and AIDS, with challenges in our country where people were denied treatment. And I saw what we do as doctors as reducing harm. And my experience in HIV and AIDS bore that out, because we ensured that treatment was offered in our country. So I came into harm reduction looking at things from a patient's perspective, that whatever our views are, there's a user on the other side who would be looking for information and for things that could improve their health. And that's how I come to harm reduction. It's not just in relation to tobacco. I've been involved with the food industry. I've been involved with hand washing, hygiene, safer foods. So it's the reduction of harm and improvement of health, and moving away from the do or die concept. People need to be provided with alternatives so that they can make informed choices.
Yes, wonderful. And I just personally want to say, it's wonderful to have you on the program, because like you said, one thing that we are attempting to do here at VIDA News, obviously we focus in on tobacco harm reduction, but having you be willing to join into the fight at all, and then to come on this program, it's part of the mission that we want people to understand, is that tobacco harm reduction is part of the overall family of harm reduction, that these tactics have worked. They have received recommendations from large health organizations in the past. And the more that we can see that, and it doesn't seem as much as a silo, I think the more, like you said, the people on the other side that have their lives affected, it's important for them to be able to realize that they do have a home here and they do have other options. I do believe that we have Joseph back. So Joseph, thank you so much for being on the program. Please take some time, if you can, to introduce us introduce yourself to our audience. Looks like we're still having some audio issues there. So as our team tries to work on that, Dr. Kagosi, I did want to ask you a question specifically, just to kick things off. So obviously, as you said, you've done a lot of work in the harm reduction space. As we were doing research for this, the former president of the World Medical Association, the former CEO of a trust that was set up to be able to help with the HIV/AIDS epidemic. You're the chair of multiple health organizations. But when I asked you in particular what title you would like for us to use, one of the first things that you said was health advocate and activist. Why is it important for you to take on those titles of advocates and activists? You're already doing the work, but can you just talk a little bit more about why that sort of like on the ground feeling is important to you?
I'm a medical doctor, and in our training, we sort of sometimes get a God complex where we want to tell people what to do. We know what's right for people. But in the more than 3 decades that I've been in private practice, I've come to understand that I'm a health advisor. I'm there. I'm an advocate for the patient. I'll provide them with information that'll enable them to make informed decisions about their lives. As a surgeon, there'd be points where I would advocate intervention so that we could improve their condition. You know, I've performed thousands and thousands of cataract operations, amongst others, but I do it in partnership with the patient. So
Yes.
I've come to understand from the HIV battle, when we got into the HIV battle, we went with the doctor attitude of trying to save people. And what I've learned, what was more important in the HIV arena, after all the challenges that the people living with HIV had, they rose to take up their own cause. And what I learned was instead of coming to them with the notion of wanting to do something for them, it became important to ask, how can I help you? And that informed me on the issue of being an advocate and an activist, but the importance of people speaking for themselves so that you listen to them, you hear what their problems are, what their challenges are, you then advocate on their behalf, become an activist for their own benefit, not for your own aims and objectives and for your ends. And that's why I'd rather be known as an activist and an advocate, because the little that we contributed to the HIV and AIDS battle, it was primarily because the people living with HIV stood for themselves. But it was important for me that those of us from the medical field assist our patients so that they can get a good check. And that would come to the same issue in relation to smoking, where my point is that smokers are human beings too, and smokers matter. And it's about how can I contribute for a better health of those that smoke.
Wow. Well, thank you for that. You know, it's incredibly powerful. You know, there's that, even that specific, you know, that specific thing that you said, that people who smoke matter. You know, that really is at the core of all of the work that I see that all of you on this panel and the other activists that we've and advocates that we've had a chance to talk to on this program. You know, that is very important. And so Joel, I wanted to ask you, you know, obviously, as you said, you were you know, fairly new, 2019 into this this fight in your home in Uganda. Could you tell me a little bit about, you said that you needed to demystify the idea of tobacco harm reduction. Can you give us a little bit of background where you are at, those people that smoke, you know, what are the current misconceptions of tobacco harm reduction, and how are you doing work to help try to demystify that?
Well, for starters, having prior experience with the tobacco control through formerly working with the ATFI, that is Africa Tobacco Free Alliance. Yes, what we learned is that basically there is the urge to want to push people off tobacco by hook or by force, so to speak. However, you get to understand if you come down to the smoker's intentions, or that, rather the experience of the smoker, then you get to understand that the approach is not. It's not about the policy, so to speak. It's actually about the individual. So what is in place is people view tobacco harm reduction products, that is safer nicotine products, as in the same light as they view tobacco. If you can see what happened, there was a Tobacco Control Act that was enacted, which is now actually which has been enacted into law, but right back in 2016. They banned all the tobacco products together with the various safer nicotine alternatives that are in the market. That is e-cigarettes. Now, this being banded together as tobacco products sensibly puts to question the understanding of the people in place at the time, because on the other hand, you have e-cigarettes which have been proven scientifically to be 95% safer than cigarette smoking. and cigarettes which are killing people, 10,000 by the number every year in Uganda. So with the benefits that have been viewed in other places, for example, England, at least you would find that there would be need for our government and its agencies to view this in good light and actually bring it down to the people so that people can get to see that there's actually an option rather than the increased number of smokers that are there buying sticks, cigarette sticks off counter in various shops around town. At least people would get to be able to access these options, which would lessen the effects as well as diseases which are related. Now that becomes a problem because it's hard to really tell where the mind of the people pushing for such policies are. They need to come down to the individuals who are actually using this, because that would help. That would put more perspective on the matter. Thank you.
Yes, definitely. And I think it's interesting that you talk about the sort of the grouping together of these products, both your combustible tobacco and then you have your safer alternatives, things like nicotine vapor technology. In other countries, there's things like smokeless tobacco or heat not burn products.
Yes.
Dr. Kagosi, I wanted to ask you, we recently had Kurt Yo on our program. It was a couple of months ago, but he was talking about the prohibition of all tobacco products inside of South Africa. Now that was just announced by the president that ban would be lifted. Do you see what in your professional opinion do you see as being the main blocker behind lawmakers and those that are in power, both in South Africa and around Africa in general, from making the determination between these products that, as Joel said, have been proven to be 95% less harmful and combustible tobacco? What exactly is it that is the disconnect with those needing to be lumped in together?
Midnight last night, the ban on tobacco products was lifted by the president. And the ban was in relation to COVID-19. Mm-hmm. We are now reduced to level 2 in terms of alertness in relation to COVID-19. But the challenge in terms of generality about issues where people want things banned, the biggest driver are two things: fear and ignorance. People are fearful, but they are also not informed. And the fear rightfully comes from the history of the tobacco industry and the camel man and the menthol stories and the denial about the harmfulness of tobacco. But it's also compounded by the fact that there are people that have made careers from being anti-smoking. And there are world authorities, they have well-paying jobs on that. And when you have something that is a technological revolution that comes up, it's a threat to their worldview. And sometimes they want to stay to that. So the combination of the behavior of the industry from before, the lack of trust, the fact that they falsified information before, and the fact that there is an industry called anti-smoking. There are careers based on it. There are organizations that are funded by billionaires, by philanthropists, and by government to be anti-smoking. And careers depend on that. People have had PhDs on being anti-smoking. So we got to be mindful of the fact that, I gave an address 7 years ago at the West Virginia Tobacco Conference to say there's a core element about this issue about addiction. But what we must be mindful of is that at the time I spoke of 3 addicts. Now I've added 2 addicts. The first addict being the industry that are addicted to the profits. The governments that are addicted to the taxes. And the smokers that are addicted to the nicotine. But you now have academics that are addicted to the fame and fortune that go with whatever their viewpoint is, whether they were anti-smoking. There's now those of us that may be addicted to harm reduction. And we need to be balanced in terms of how we approach these issues. And we need to remember that we need to be frank, open, and truthful in our engagements on these issues. And that is why people tend to go to prohibition, because it was part of the empower concept of dealing with tobacco. What people have not taken into account is that today we're not in the position that we were in 20 years ago, where when you spoke about nicotine and tobacco, beyond nicotine replacement therapies, there were no other alternatives on the table. We're now in a totally different position now, where there are alternatives. Some were there before that were denied, if we have to talk about this story. So in summary, the key issue is that the harm is related to combustion. And when you look at alternatives that are non-combustible, we can then look at greatly reduced harmful constituents in those products.
Wonderful. And Joel, do you have anything to add to Dr. Kagosi's points there?
Well, just like he's broken it down quite well. Indeed, the issue is the harmful constituents that lay in the combustible tobacco products. If this is able to be put in check, then you find that the number of cases in terms of the people who are ill, the people who are dying of cigarette smoking related effects would greatly reduce. Now, this is the challenge, because as it's been said, research shows that right now there's over 6 million people dying annually because of cigarette smoking and tobacco use related effects. However, it's projected that by the year 2030 it will be over 8 million persons globally. Now, and it is actually said further that 80% of this will be coming from the low and middle income countries. And coming from a country that actually lays very steadily and well within that range. I mean, our human development index is quite is not good. So, being the case, I would strongly recommend that actually our countries need to adopt and come to a point of acceptance that tobacco harm reduction is the way to go, and better yet, devise means and innovations that will actually encourage this, make it accessible to the user, make it an option. Don't make it an evil, but rather accommodate it, encourage it. Yeah.
Yes. And you bring up a really interesting point, and I want to pose this question to both of you. Now, obviously, we know that a lot of tobacco control around the world, especially in these low and middle income countries that we're talking about, a lot of that tobacco control policy is really dictated by the WHO, the World Health Organization, and the Framework Convention for Tobacco Control, the FCTC. We had a panel of experts from India that were on the program actually talking about this, and the suggestion was floated that maybe it is time to revisit that convention, to revisit the FCTC. Dr. Kagosi, I wanted to pose this question to you first. Do you believe that there is a path forward to tobacco harm reduction and not prohibition with the current framework that we have in place? Or do you think that it is something that could potentially be too general, and that maybe more of that power should actually be given to individual countries or regions to be able to come up with policy that best suits the people that live there?
I think the problem with the FCTC is that people have taken to it like a religion. And that has become problematic. But even in the text of the FCTC, there is language that refers to harm reduction. But at the time that it was written and the harm reduction concept was embedded in it, there weren't many products that were less harmful at the time. And it is just unfortunate that with the advent of technology producing more products that are less harmful, that it is being misrepresented and misinterpreted. There's also a lot of, if you go to Article 54, where you don't talk with the industry, there's some form of dishonesty around it. If you look at China, for example, the tobacco industry is controlled by government. And the WHO speaks to the Chinese government all the time, even though they are the single largest producer of tobacco on the globe. But they talk to them. But they don't talk to others who do not run government. So there's an element of dishonesty. But embedded in the WHO framework, what is the biggest lesson for them is that many years ago they banned snus, which is the first product that is non-combustible, that we have good epidemiological evidence on. They've banned it, but Sweden got an exemption because that's where the product originates from. 30 years later, the WHO will show you studies where the Swedes have the lowest morbidity and mortality related to cigarettes, related to tobacco. And they have the lowest incidence of combustible tobacco use in their society, where snus, smokeless tobacco, which is not combustible, has displaced combustible cigarettes with tremendous health benefits to the population. And the WHO was the advocate for the banning of snus. There is a prime example where bans don't work. And it might be correct for all the citizens of the European Union who have been denied access to a less harmful product by their governments. They should be suing them for not having exposed them to less harmful products.
Exactly. And the fact that those products
FCTC, we can see the challenges about banning, the challenges about people not being truthful, and the harm that accrues to society. So yes, the FCTC is a good framework. It's an essential framework, but it has to be amended to be appropriate for the times. I will talk later, if you give me an opportunity, about what is impending in South Africa in terms of our Tobacco Control Act being changed and having to go through Parliament.
Yes, definitely. And I think that is very interesting. And I really do hope that itself, the amendment to that, obviously the Conference of Parties that was slated for this year was moved to next year because of COVID. People could not gather. It will be very interesting to see if that is a topic of conversation for this, and if the voices can be loud enough to call for an amendment like that. Joel, I wanted to ask you as well if you had any follow-up parts to what Dr. Kagosi just said, and then a second part. Obviously the WHO has that. We're talking about this paper that the union actually put out, claiming that bans are best in these LMICs. So I wanted to know as well, what were your first thoughts when you read that, a paper that was authored and did not seek to have the expertise of experts and advocates from LMICs take part in it, but when you saw that they were calling for outright bans, what were your first thoughts?
My response to the first part, I do appreciate Dr. Kagosi's input. Indeed, I'd like to see a situation where the Swedish experience is copy and paste, so to speak, here in Africa, because the snus experience is one that is quite remarkable. Very little effect. People are thriving. A lot of research around it that actually proves that it is actually working. And in response to the second question, it actually, I find it to be a bit ridiculous that this would be that this would be adopted. Why? Because if you actually came down on ground in Africa, for example, where you find that people actually having the day-to-day struggles, but still find a way to afford smoking, buy a cigarette, put yourself in harm's way, and that not being challenged, it becomes a problem because cigarettes are actually bought, readily available. It is preposterous to imagine that you could actually be able to access cigarettes. But in this 21st century, where innovation is actually speedy, things are changing rapidly. We need to go with the times. Still, in that sense, find it difficult to be able to allow products like e-cigarettes be readily available. It becomes quite interesting. So I find it that in my own view, I find it I don't rather I don't find it I find it not right, because the people who actually experience these problems are people who have not been consulted or involved in the decision-making process, or even so in the write-up itself. So that is a bit off for me. Thank you.
Yeah, that's a very common refrain that we have heard. You know, that specific, I mean, that specific point right there is part of the genesis of why VIDA News exists, because of, you know, people that are involved with these, you know, the day-to-day consequences of these policies. Those people being removed from WHO hearings, not being able to speak to that. A lot of this happening in secret. And Dr. Kagosi, you know, I know that you were mentioning some different things that are happening in South Africa as trying to work through that. I would love for you to give us a little bit, give our audience a little bit of information. Just take us behind the scenes on how some of those decisions, you know, how they could be made better, how maybe that might be taking place in South Africa.
Yeah, I'm looking forward to that process starting in Parliament. And unlike other people recommending bans, we will want to engage, and there should be open dialogue, and the different parties can give input. But it was quite concerning that the proposed amendment is going towards abolitions, being abolitionists, where they want to tar everything with the same brush. There's no distinction between the different ways in which you can get your nicotine. They want everything that delivers nicotine to be treated the same way as tobacco is treated. So there's no differentiation. And we hope we will engage and educate about the fact that these are different products. They have different degrees of harm. And you need to look at them with different lenses.
Correct.
I was part of the MCDA where we looked at the issue of harms of alternatives to combustible cigarettes, with the combustible cigarette as the reference point. Yeah. And when we engage in this discussion, anyone that would purport that e-cigarettes are more harmful or snus is more harmful, they need to be asked to provide the evidence of the harm of the product relative to the harm caused by combustible cigarettes, with combustible cigarettes as the reference point. I mean, it's interesting that the FDA has just allowed the heat-not brand product IQOS to make certain claims about reduced constituents of harm. It rightfully said it can't claim to be more beneficial than combustible cigarettes because that would require long-term studies. So we hope everything, excuse me, will be evidence-based. It would be correct. About the science. I mean, it's quite interesting that in the middle of COVID, WHO talks about looking at the science. And we hope, even in relation to nicotine and tobacco, they will look at the science openly and truthfully. And I can't wait until we can give evidence to our parliament about a proper framework that differentiates between the different forms of nicotine and the harms associated with the different ways of delivering nicotine, and accepting the overwhelming evidence that the greatest problem associated with tobacco is if you get your nicotine through combustion.
Yes. I mean, that's amazing. So many really important points that you make there. And especially that idea of, first off, that idea of the relative harm, the harm compared to combustible tobacco. We see that all the time in a lot of studies, or a lot of, not necessarily studies, but just the media coverage of that, both in the United States and around the world, about the potential harms of these products instead of the relative harm compared to the thing that as Joel mentioned, in coming years, predicting that it's going to kill 8 million people across the globe every year for that. Joel, I wanted to ask you, in the work that you actually do, in the work that you actually do in Uganda, and the people that that have found, that have found these products, how has COVID itself and the lockdowns around that impacted people's access to the products in Uganda? Obviously, we've heard from different countries around the world that have used COVID as a reason to be able to stop people from gaining access to any type of product like that. Has that been the case in Uganda? What has that been like for you?
Well, for starters, as you know, in Uganda, the products are banned.
Mm-hmm.
So it creates a situation where they are more or less accessible through dubious means. There's various traders who bring in the items and they sell them on various online platforms. But access has been impeded by the very sense of the ban itself. You find that if somebody wanted to be able to access e-liquid, it would be through a dealer in some particular place. Now, the contents themselves are put to question. You really, really never know, because there's no regulation, there's no monitoring of what is coming in, what is going out. So that becomes a problem. So yes, the COVID period has been a bit challenging for people, for the basically safer nicotine alternatives users that I know, or rather the ones I've interacted with, because here in Uganda, there's also the situation where all our borders were locked. It's only a particular system that would allow goods to come in, but not travelers per se. There was no cross-border exchange or communication, or rather travel. But every good that kept on coming in was checked highly at a particular level of scrutiny. So it was a bit hard to access safer alternatives, so to speak. So as far as I know, in my research and in the people I've engaged, as well as information that I have, you would find that there was more cigarette use in this period, and people kind of went back to cigarette use to be able to access nicotine, unlike the cases before. The few people that I know, anyway, the ones that I've engaged, that is.
Yes, and that's really interesting. I was reading a study that was conducted, I believe in June. It was either June or July. A university in Cape Town that actually showed that the increase in illicit tobacco sales was up somewhere in the neighborhood of 250%, and the price markup on that for people that were hit hard in the economic downturn added into that. And then also, interestingly enough, a lot of the times these bans, especially with COVID, were put in place. Partially the reasoning is that people share either devices or cigarettes, but that same study found that it was a 400% increase even in the sharing of those, which could further exacerbate the pandemic that we're in. I also want to add that I mentioned Kurt Yao earlier in the program. He's actually watching right now, commented on Dr. Kagosi's part, saying that South African governments need to open consultation with all parties equally, that they need to speak to the users of these safer nicotine products. And I think that is a very common refrain that we see all across the board. And speaking to the point that Dr. Kagosi had earlier, the idea that these products are shifting and that they are changing and that people want to have access. We heard that echoed in our Latin American panel last week. We heard that from our Indian panel as well. And Dr. Kagosi, I wanted to ask you a question. I know that I saw a video with you where you actually said that healthcare providers, yourself included, have a responsibility, you said, to assist with people, especially in those that are preventable diseases, that is the responsibility. If it can be prevented, healthcare providers should do that. And I know that you echo that, but in your opinion, can healthcare providers claim that they are assisting in helping stop preventable diseases if at the same time they are advocating for the bans of these alternative products?
No, they will not be assisting. And remember that there would be issues of groups and group mentality where rationality seems not to be the thing. There'll be a leader of the pack and others are followers. And it becomes more like a religious front rather than an academic group. And that is regrettable. But fundamentally, the point I make is that when you sit with a patient in front of you, in terms of the oath that we have, you have to act in the best interest of that patient. So if a person is smoking 40 cigarettes a day, and we all know that that is the biggest cause of preventable harm to that person, it is your duty as a physician to be able to advise them. But we know that quit or die doesn't work. We've seen people that have been treated for lung cancer and they're still smoking because we've never told them what alternatives there are. When we have people that are heroin addicts, we give them methadone. We give them less harmful things because we know that, say, quit or die does not really work. It's not helpful to the patient. So you'd have an ethical duty to educate yourself and inform yourself on alternatives. I mean, simply put, we advocate nicotine replacement therapy, which does not work well, but we advocate it as an alternative so that you can get your nicotine and avoid the combustion. What is wrong when there are alternatives, nicotine alternatives, that might be more appealing to smokers than the lozenges or patches? What is our ethical duty in those circumstances? We'd have an ethical obligation to inform ourselves and to be able to inform our patients so they can make informed choices. It's not our duty to act like pastors. I'm not your divine leader. I'm just a healthcare professional here to assist you. And I have an ethical obligation to give you all the information that is available so that you can make an informed choice.
Yes, wonderful. Well, that is fantastic. I want to be mindful of your time, gentlemen. So I think we will wrap up the conversation there. But I do thank you so much for your time. We made sure to put up Twitter handles and in the links of all of this where our audience can be able to find your work. And I thank you. And I can guarantee that this is not the last time that we will be speaking. So thank you so much for joining us today.
Thank you, Dom.
Thank you. And I think, Dom, abolitionists must just learn from us. In the last 5 months, when we banned cigarettes, it never stopped people from smoking. It just made it more difficult, more expensive, and we just increased harm to themselves. Because now the competition for their wallet between cigarettes and other essentials like food was much more severe. So we just made it more difficult for them to get their smokes, more expensive, without the safety profile, the benefits that we had to the system. The harms that came to the system outweigh whatever benefit that we may have received. But I think the main lesson is for people to understand, when you ban something, you're just driving it underground and you're exposing people to more harm.
This is true. Demonizing it, I agree, doesn't help. It actually worsens the situation. Because if our countries and our governments are able to understand that safety is primary in all aspects of life, then this would help govern the understanding of what tobacco action harm reduction is at its very core. Because there's no reason why you would allow, the understanding of safety is you have condoms in place for safe sex. You have face masks right now, personal protective equipment. Why then not put in place measures and tools and even so innovations that are able to support the longevity of life, the quality of life for people against against smoking, That's my take.
Yes. And I'm glad to have both of you on that fight, pushing for that, exactly. The reduction of harm, the care for individuals that are just like you, just like me, just like our family, just like our friends. So thank you so much, gentlemen, and I look forward to being able to continue this conversation again soon.
Thank you so much.
Thank you for the opportunity.
Yes. Okay, that is our program for today. As I end all of these panels, the conversation is done with us on video right now, but that certainly does not mean that it is over. Please continue to have this discussion. This is very important, and you hear points that are echoed here that we have heard from India, that we have heard from Latin America, that I'm sure we will continue to hear over and over again. So please make sure to share this video, to send any more comments that you may have, any more questions that you have. We will make sure to follow up with our guests. We will also make sure to follow up with Joseph as well. Unfortunately, we lost him early on in the broadcast, but we'll make sure to track him down and make sure that he has an opportunity to answer all of these questions as well. As always, thank you so much for tuning in. Make sure to follow us at vida.news for all of your updates for different documentary spotlights, tobacco harm reduction updates for all around the world. And I look forward to seeing you again very soon.